The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
Welcome, everyone. Thank you for taking time out of what we all know are busy days and long days and busy evenings. So I think there's some important messaging to communicate tonight. I'm a urologist who specializes in sexual and reproductive medicine. I've been doing this for 29 years. I work at Memorial Sloan Kettering Cancer Center, and about 30% of my practice is involved low testosterone, frequently in men with prostate cancer, but in other areas in the cancer and non-cancer space also. As is kind of required of us, I'm going to present some labeling information. I think there's a lot of interesting things to talk about in the label. The first thing is that this is not necessarily what guidelines say. The label is what the label is, and we are bound when we prescribe a medication to prescribe on label unless we make a judgment call that we want to move in our best judgment off label. I am the chairperson of the AUA guidelines. It got published on testosterone deficiency and management, and that got published in 2018. It was updated last year. So I've got some ideas on a variety of things that are on the label. I think when you look at the indication for KYZATREX or any testosterone therapy, it is in men with a diagnosis of testosterone deficiency, which is T levels technically below 300 on 2 occasions using a good assay, the same lab, in association with symptoms and or signs. And I think that's an important distinction, that it's not just low T, it's low T associated with symptoms and signs. I think the label makes way too much about this concept of primary and secondary hypogonadism, so hypogonadotrophic versus hypergonadotrophic. There are men who have low T and symptoms and meet the definition of testosterone deficiency, who don't have a testicular failure that it's overt and don't have a hypothalamic lesion, for example. And they have what is often called functional hypogonadism. And if they meet the definition as I described earlier, I think they're warrant consideration for testosterone therapy. At the bottom of the slide, you will see the blood pressure increase warning. This is now in the label, or will be in the label shortly, for all testosterone products. And the last several testosterone products, including all of the oral testosterone products, there were studies done during the registration trials to look at blood pressure changes, and there are clear indication that there is a mean change of about 3 millimeters of mercury, which, very interesting in post-market release analyses, is most likely to occur in men who are diagnosed with hypertension, who are using antihypertensives. So in those men who don't have known hypertension and are not on antihypertensives, there is really in the range of about a 1 millimeter of mercury increase in blood pressure. Testosterone has a mild mineralocorticoid effect, and it's likely that this is due to its volume expansion. So at baseline, check BP, and in your regular follow-up with patients, monitor their BP. So if you look at the contraindications here, halfway down the slide, you'll see that prostate cancer and breast cancer are on there. So index patient is the male, so we're not going to ignore the female use or pediatric use. Males, index patients, males over 18 years of age. So of course, as if you're a urologist, you'll probably become very comfortable or familiar with testosterone therapy in the prostate cancer population, even though the label says you should not do that. It is off-label to use it in prostate cancer patients. But working at Memorial Sloan Kettering Cancer Center, we have extensive experience in patients who have prostate cancer, post-prostatectomy, post-radiation therapy, active surveillance patients on testosterone therapy as an off-label treatment for men with profound hypogonadism or testosterone deficiency. If you look at the concept of polycythemia, of course, if a man has a baseline hematocrit of 50% or greater, we should not be giving those men testosterone therapy, and we should be investigating why they have elevated hematocrit in the setting of having low testosterone. And by the way, the most common cause of that, men with low T who have hematocrits above 45%, the most common cause by far is obstructive sleep apnea. So at Memorial Sloan Kettering, every patient who goes on testosterone therapy gets screened with the stop-band questionnaire, and if that is moderate to high risk, they're told to get an HSAT, a home sleep apnea test. And this will circumnavigate the problems with you having patients going into a polycythemic state and required to coordinate therapeutic phlebotomy in those patients. From a cardiovascular risk standpoint, the AUA guideline says that men who with low T should be counseled that low T is a risk factor for the development of major adverse cardiovascular events. We had a cardiologist on the panel who opined and wanted that in there, and the literature supports that idea. However, testosterone therapy in the guidelines, the risk-benefit ratio was unclear. And this is largely based on what were 3 papers, Basaria, Finkel and Vigan in 2010 to 2014, suggesting that T therapy was associated with major adverse cardiovascular events. Since then, however, several meta-analyses, Giovanni Corona, Mario Maggi's group from Florence has published a beautiful meta-analysis suggesting that that is not the case. And then, of course, most recently, the Traverse trial for 5,400 patients, randomized controlled trial following men for more than a year, showing that there is no link between testosterone therapy and the development of major adverse cardiovascular events. So I think it's safe to say now that that is not the case, and the FDA have committed to changing the label, the black box warning on adverse cardiovascular events. At the very bottom of the screen, you'll see worsening of BPH and potential risk for prostate cancer. There is no data whatsoever in the AUA guidelines, systematic review with meta-analyses, that testosterone therapy in randomized placebo-controlled trials, is there any higher risk of prostate cancer in those receiving T versus those receiving placebo? There just isn't data. And the guideline statement is that men should be told that testosterone therapy does not cause prostate cancer, and it most certainly doesn't cause increased prostate growth or lower urinary tract symptoms. In fact, in the prostate safety paper from the Traverse trials, which was a separate paper, there was no increased risk of acute urinary retention, no increased risk of prostate enlargement or worsening LUTS. VTE, very interesting. So secondary polycythemia leading to venothromboembolic events. The AUA guideline says clearly, although there is a warning in the label, that there is no increased risk of VTE in men who have testosterone therapy in randomized placebo-controlled trials. And that still is held true. And in fact, the Traverse study confirms that. If you work down the list, adverse events, the most common adverse event with KYZATREX is hypertension at about 3%. We've already discussed that. You'll see drug interactions here, and use in specific populations such as pediatrics and females is not permitted as per label. So listen, I think you're all aware that there is a big need for testosterone therapy. I think there are lots of men who are candidates for testosterone therapy who don't get it. But I also think there are many men who are getting testosterone therapy who are getting it in an inappropriate fashion. I already talked about the definition of testosterone deficiency, T levels below 300 in men with symptoms and or signs. I think it would be fair to say that guidelines are not a biblical dictum, and we as clinicians should be using our clinical judgment. And there's no doubt that there are men who have T levels between 300 and 400 who are profoundly symptomatic, who warrant consideration for testosterone therapy. And the presumption is that they had baseline T levels perhaps in the 500, 600, 700 range, and they have a 300-point drop and they're symptomatic because of that. And I think that's perfectly reasonable. It is very, very rare that I'm going to treat somebody with a T level above 450 with testosterone therapy. And the rare exception to that would be perhaps a man who had testis cancer, who had an orchiectomy, who had 4 cycles of EP, and he comes in with a T level of 440. It would be hard to believe that that T level is the same as his T level was before his chemo or before his orchiectomy. This is a survey of 770 men who completed the quantitative androgen deficiency in the aging male, the Q-ADAM questionnaire at KYZATREX.com. And you can see here that these are the classic symptoms of low testosterone. The problem with the symptomatology, however, is that they're also the symptoms of chronic stress, chronic fatigue, depression, perhaps obstructive sleep apnea. So one has to be very careful when one uses these symptoms as the primary indication for testosterone therapy in men who don't have low testosterone levels, as I've discussed a little earlier. So the evolution of testosterone therapy, going from left to right here, you can see, I won't go through this in painstaking detail. I entered the fray in 2000. I was on the advisory board for the original androgel. And so for the last 25 years or so, I've been involved in the testosterone space. And I think there's been a wonderful expansion with a variety of options available to patients. And of course, as you're probably aware, if you prescribe testosterone, patients are interested in cost and what suits them, what is integratable into their life. There's some men who will say to me, you must think I'm crazy if you think I'm going to inject myself with a needle. And then there are other people saying, well, why wouldn't I inject myself when there's a 100% chance of having excellent T levels in response to intramuscular T? So I think patient preference and cost are major factors. So if you look at these factors, easy to swallow, invisibility, absence of a mess, and painless and flexible dosing, it's not rocket science to understand that oral therapy would meet all of these criteria, and many of the other therapies do not meet that. And I think it's worthy of discussion with patients when you're discussing therapeutic modalities, what's important to them. Is it their T levels? Is it the ease of access? Is it the administration? There are two ways that you're going to get yourself into trouble prescribing testosterone from a medical legal standpoint. Okay? Number one is the risk of transference. So there are groups of patients in my practice who will not be allowed to use transdermal testosterone. And they are patients who come in regular contact with children, male or female, 12 years of age or under. So for example, a grandfather who's a caretaker to his 6 and 8-year-old granddaughters. I would be very concerned about the risk of transference in that population. Also, there are patients, men who deserve testosterone therapy, who are obstetricians or pediatricians, or who have regular contact with children in other settings, guidance counselors, school teachers, etc., where I think you need to be very, very careful. It is absolutely critical that you document in your medical record, if you're prescribing T, that is exogenous, that is transdermal, that you've had a conversation about transference. The second thing that's going to get you into trouble is going to be the risk of impairment of spermatogenesis. Exogenous T, the guidelines state very clearly, patients who are interested in fertility currently or in the future should not be using exogenous T because it suppresses gonadotropin secretion and in the long term may cause permanent problems. So you must document that you've had a conversation with those patients about exogenous T and the link with impairment of spermatogenesis. And of course, there are other strategies available to patients who are interested in fertility, such as SERMs like clomiphene and enclomiphene, HCG, and also aromatase inhibitors. What's very interesting, and I'll show you some data in a second, there is relative preservation of gonadotropin secretion with the use of KYZATREX. So I think you've all encountered patients who, when you say intramuscular testosterone, they go white in the face or pupil dilation because of the concern about using needles. And there's a gross needle phobia, of course, in the Western world. And this is a survey of physicians. 41% of physicians agree that patients often complain about injectable testosterone. That is true in my practice. Okay. Although there has been an increase over the last decade in the utilization of intramuscular T over transdermal for a variety of reasons, at least preceding the introduction of oral testosterone therapy. So following on from that, the acceptability and the integratability of oral therapies compared to injectable therapies, well, this has been well documented in the rheumatoid arthritis field and also in type 2 diabetes, where patients have a preference for oral therapy over injectable therapies. And I think that is highly individual, but I think is a topic of discussion for you with your patients. And I think it's very important that patients are made aware that oral therapy is available, whether they're covered by insurance, whether they're willing to pay the money for KYZATREX, they should know about it at least, and it should be presented to them as a therapeutic option. And in my practice, we actually have a sheet with every testosterone product on it, and we encourage patients to define with their prescription plan what's covered. So KYZATREX is testosterone undecanoate. And so this is a really important concept, because if you're above 45, 50 years of age, you probably remember oral therapy is associated with liver damage. However, testosterone undecanoate is absorbed through lymphatics when co-administered with some level of fatty food. So that's important to understand. It bypasses first-pass metabolism. It's not hepatically metabolized, and therefore into the lymphatics, and it is safe from a liver standpoint. If you look at clinically proven efficacy, up to 96% of patients achieve normal T levels at day 90. Okay, that's a very high level of normalcy. And at day 90, mean free T levels increase twofold, and SHBG levels, as is usual testosterone therapy, dropped by about 30%. And the importance of that, of course, is that when our SHBG levels are lower, that allows more testosterone to be free. About 2 to 4% of testosterone is free, and if your SHBG level drops, then your free quotient goes up. And it is believed, and I think reasonably so, that the free testosterone is the more biologically active component of testosterone. The total T level, most of it, 96% or so, is bound to proteins such as SHBG, albumin, corticotrophin, binding globulin, etc. So KYZATREX is an oral agent. There are other testosterone undecanoates, but it has a unique formulation, and you can see the kind of details of that here using a self-emulsifying drug delivery system, and basically ensures that it gets absorbed lymphatically and bypasses hepatic metabolism, ensuring hepatic safety. These are the pharmacokinetics, the plasma T profile. You can see on the right-hand side mean plasma and mean serum T levels, Cmax, Cmin, and C average. I would focus on the C average, and you can see that in the trials, these C averages are within the therapeutic range. And that is all that is required of companies when it comes to proving that this is an efficacious agent. It has good serum T levels. And if the patients are selected correctly, good serum T levels should translate into symptomatic response or improvement in conditions such as bone density loss, improvement in glycemic control, and reduction in major adverse cardiovascular event risk. Mentioned already on 2 occasions the link between testosterone therapy in general. This is not KYZATREX. This is not just oral therapies. This is all oral therapies. In fact, the blood pressure changes are probably most prevalent with intramuscular testosterone because of the very high T levels and the increased mineralocorticoid effect of a T in that modality. And then increase in hemoglobin. 1.9% of patients had a rise in hemoglobin. And if you take a man with low T, whose hemoglobin is 45% or lower, it is very unlikely, if you put them in the therapeutic range, that they're going to have a significant rise above 50 or 52% in their hematocrit. The patients you need to be worried about, again, are those who have low T, who have hematocrits 48%. The mean change in hematocrit in my practice, when people go from very low T levels to normal T levels, is in the 4% range. So if you're 48%, you're going to go to 52% if you're carefully selected. So be careful. There are the patients who you need to think about obstructive sleep apnea. So I kind of alluded to gonadotropins earlier on. So you can see baseline versus day 90. And the first graphic is free testosterone with an increase in free T. If you go directly below that, you'll see a reduction in SHBG, and any androgen therapy is going to reduce your SHBG levels. Okay, and by reducing SHBGs, we increase free testosterone. If we move to the right-hand side panels, on the top you've got FSH, and the bottom you've got luteinizing hormone, and you'll see that you do not have complete suppression of gonadotropins, which technically, although not yet fully explored in post-marketing analyses, if your gonadotropins are still present and not completely suppressed, then perhaps this could be looked upon as a fertility protective form of testosterone therapy. The average PSA rise here, you can see very low. The patients in whom you need to be concerned about significant PSA changes are those men who have a baseline T level that's very low, below saturation point, certainly below 250 and probably even below 200. They're the patients who should be told, we might see a change in your PSA because your T currently is below saturation point. But if your T level is above 250 and you're treating those patients, it's very unlikely that you're going to see any significant change in PSA. The mean change in hemoglobin was at less than 0.5 gram per deciliter, and you can see lipid changes and insulin changes here. And much of this is probably mediated through reduction in visceral adiposity in men who go from a hypogonadal state to a eugonadal state. If you look at the PROs, Okay, patient-reported outcomes, whether you use psychosexual daily questionnaire, a short-form health, the SF-36, or the IIEF, you'll see significant improvements across a wide variety of parameters. Overall increased level of sexual desire, increased rates of positive mood, sexual activity score, erection grade, erection duration, less fatigue, greater energy, overall improvement in social functioning, and then from an erectile function standpoint, some improvement in erectile function, intercourse satisfaction, and improvement in orgasmic function based on the IIEF-15. So from a practical consideration standpoint, Polly alluded earlier on to the cash-based system that KYZATREX uses. This is one of the reasons that I and my practice is enamored with the use of KYZATREX, because it actually reduces significant burden associated with pre-authorizations and getting various testosterone products approved for our patients. So it is certainly much easier for us. Yes, there are patients who are not interested in paying $150, $159 per month for testosterone undecanoate in the form of KYZATREX, but I'll tell you, this has had ready acceptance at my practice at Memorial Sloan Kettering. It eliminates the need for prior authorizations, reduces insurance hassles. That's a significant burden in our practice, as I think we're all aware, and simplifies the prescribing process for both providers and patients. There's cost predictability, transparent pricing ensures patients know their out-of-pocket expenses and avoids unexpected costs and insurance-related delays. That's not an insignificant consideration. It's not uncommon in my practice for patients who commit to testosterone therapy, whose prescription goes in the day we speak to the patient, are waiting at least a month to get their testosterone therapy because of insurance hassles. Patient convenience, oral administration means no need for in-office visits. Most of our patients on intramuscular T, we train them to do that themselves, and we do not do it ourselves in the office. And it's easier for patients to integrate into their daily routines. The dosing on KYZATREX is twice daily, as it is for most oral therapy. And generally speaking, as you saw from that graphic earlier on, the pharmacokinetics, that is a 12-hour drug. So technically, you'll be using it 8 o'clock in the morning and 8 o'clock at night. While this is off-label, there is increasing utilization of this, and then at breakfast administration, and then an at lunch administration. So those first 2 meals of the day using KYZATREX, and it is generally believed that that will most closely replicate the circadian rhythm, given that T levels are highest within 2 hours of waking and tend to drop over the course of the day, with the lowest T level being somewhere between 4 and 8 p.m. And that's how I dose KYZATREX, breakfast and lunchtime. So in managing patient expectations, I think it's important that we educate patients that while injectable therapies can lead to high peak levels, such levels are not necessarily for symptomatic relief. In fact, there's very good evidence that there's no major benefit to supraphysiologic levels outside of muscle bulking. That really, the AWA guidelines says that you should target the middle tertile of the range, which is 450 to 600. And that's what the target should be. And as you saw from the pharmacokinetic slide and the serum T levels with KYZATREX, those therapeutic levels are routinely accomplished. So KYZATREX is designed to maintain testosterone levels within a medically appropriate range, middle tertile of the range, I would consider ideal. I think it's not unreasonable for you to have a brief conversation about why there's a difference between total and free, and the importance of free T and the importance of having elevation in free T. And I think, as I've shown you earlier on, KYZATREX accomplishes that beautifully. Guiding patients transitioning from other forms of testosterone, I think it's important to explain to patients that KYZATREX doesn't induce supraphysiologic spikes, as perhaps intramuscular T levels do. And by the way, if you're using intramuscular T, we would typically be doing that on a weekly basis as opposed to a 2-weekly basis, where you have to use very high low doses of IMT with a very high peak, and usually the last 3 to 5 days, the patient's T level is subphysiologic. Counseling new TRT patients who go straight onto KYZATREX, setting expectations that T levels will begin to normalize after the first dose. And many patients see symptom improvements within the first few days of treatment. And if you look at what symptoms improve early, energy, fatigue, and libido are the ones that typically improve early. And if you're looking for strength and endurance or cognitive changes, they will typically take 2 to 4 months to really manifest. Addressing common side effects, it's very important that we talk about the potential risks, besides the benefits, the risks, to inform patients that a slight increase in blood pressure, and we should be monitoring a patient's blood pressure if we're using any form of testosterone therapy for these patients. And of course, emphasize the importance of regular monitoring. The guidelines suggest that patients on testosterone therapy should be getting T levels and some other sundry tests done at least every 6 months. If that patient is over 40 years of age, the recommendations from the AUA guidelines would be that includes a PSA, and I would strongly recommend that all of these patients have follow-up estradiol levels and follow-up hematocrit levels also.
If you'd like to learn more about KYZATREX pricing, or if you'd like to get started, you do have a couple of options here. So if you're ready to start prescribing, please use the link that we're going to share via email following the event to access the official order form. And if you have any clinical, operational, prescribing related questions, we're happy to support you. We please just ask that you reach out to your menMD account manager to schedule a one-on-one meeting with the representative. As for the QR code on the screen there, that is to get more information on FAQs from the prescriber and provider standpoint. So go ahead and scan that while you can, and we'll send the rest of those links via email in the following day.
If you found this video helpful and want to stay in the loop with our growing men's health community, be sure to subscribe to our channel and click the bell to be notified when new content is available. Your support makes it easier for other men like you to find these helpful resources. Thanks again for watching. We hope to see you again.